Osteogenesis imperfecta is a genetic disorder where bones become fragile and their mass lowers. The severity of this disorder ranges from fractures and natal lethality to mild forms and no fractures. Extraskeletal manifestations can also be associated with this disorder. Blue sclera, dentinogenesis imperfecta, hyperlaxity of ligament and skin, hearing impairment, and Wormian bones present on skull radiographs. Most diagnosed with this disorder are found to have a mutation in one or two genes that encode for the alpha chain of collagen type 1. These include COL1A1 and COL1A2. Diagnosis is based mainly on signs and symptoms. Emphasis has been put on the presence or absence of blue sclera and dentinogenesis imperfecta, although there are limitations. Since blue sclera is common in healthy infants, it is very hard to diagnose in that age group. With dentinogenesis imperfecta, a diagnosis is more evident in primary teeth than permanent ones. Radiological and histological exams can show abnormalities even with individuals with normal-looking teeth. Hearing loss is rare within the first 20 years of life, but audiometric abnormalities have been recorded in large percentages of children and adolescents. About half of the patients over 50 years of age report hearing loss. There is no agreed minimum criteria established for a clinical diagnosis for this disorder, so when bone fragility is not accompanied with extraskeletal abnormalities, osteogenesis imperfecta is an easy diagnosis when the individual has a positive family history. But when there is no history in an individual's family, a diagnosis can be a bit difficult. In this situation, the collagen type 1 genes can help provide information. The amount and structure of type 1 pro-collagen molecules are observed from patients' cultured fibroblasts. Another alternative is extracting genomic DNA from white blood cells. The COL1A1 and the COL1A2 regions can be screened for mutation with both of these methods. 90% of all collagen type 1 mutations can be detected. Hence, the positive outcomes can confirm osteogenesis imperfecta, but with negative outcomes, osteogenesis cannot entirely be ruled out. Since there is a wide range of severity, a system has been made to categorize by type, to be able to prognose and assess the symptoms. The order of severity is dictated by type 1 being the least severe and type 2 being the most severe. Type 1 is mild and non-deforming, with normal height or mild short stature. Usually includes blue sclera with no dentinogenesis imperfecta. The mutation for type 1 is a premature stop codon in COL1A1. There are vertebral fractures that can lead to mild scoliosis. Type 2 includes perinatal lethality. This is usually because of respiratory failure resulting from multiple rib fractures. They do have pronounced deformities, broad long bones, low density of skull bones on radiographs. They do have dark sclera and dentinogenesis. The mutation for type 2 is glycine substitution in COL1A1 or COL1A2. Type 3 includes severe deformities, including short stature, triangular face, severe scoliosis. They do have grayish or white sclera, dentinogenesis imperfecta, and the mutation is also glycine substitution in COL1A1 and COL1A2. Those with type 4 have moderate short statures, mild to moderate scoliosis, grayish or white sclera, dentinogenesis imperfecta, and their mutation is glycine substitution in COL1A1 and COL1A2. Type 5 has moderate deformities with mild to moderate short stature, dislocation of radial head, white sclera, no dentinogenesis imperfecta, and the mutation for this one is unknown. Type 6 has moderately to severe deformities. They are moderately short. They do have scoliosis. They also do not show blue sclera and no dentinogenesis imperfecta. The mutation is also unknown. Type 7 is moderate deformities, mild short statures, no blue sclera, no dentinogenesis imperfecta, and the mutation is also unknown. Collagen type 1 molecules consist of 3 polypeptide chains, 2 alpha-1 and 1 alpha-2 chains. To intertwine the chains correctly, they must have a glycine residue at every third position. The most common abnormality is a point mutation that affects glycine residue in either COL1A1 or COL1A2. Cells with this mutation have a mixture of normal and abnormal collagen. The different variety of phenotypes is due to which of the 2 alpha chains is affected, the position where the substitution arises, and or which amino acid is substituted for glycine. The mode of inheritance is undetermined because genotype-phenotype correlations are too weak to predict a phenotypic effect of a particular glycine mutation. The most common medical managements are physiotherapy, rehabilitation, and orthopedic surgery. Therapeutic efforts aim to get the most out of mobility and other functional capabilities. Physical activity programs are highly recommended even though fractures is a high risk because it prevents immobility-induced bone loss. Standing and walking might only be achieved after the femora and tibia have been straightened with intramedullary rods. Unfortunately, medical treatments are highly unsuccessful for osteogenesis imperfecta. Medical approach to strengthen the bones is highly done because bone fragility cannot be changed by these management treatments. Clinical trials have seen decline in chronic bone pain within the first few weeks of the trial, also an enhanced sense of well-being and increased muscle strength, but further trials need to be done to establish efficiency and safety of any treatment, especially in kids.